Hi everyone, welcome to Facebook Live revision sessions. For those of you that haven't met me or watched one of these yet before, my name's Emma. I'm the lead tutor at Pure Training and Development, and we're creating a few of these different revision or refresher topics to help you revise, update your knowledge on the go in nice short periods of time, so you can just keep going forwards with your current knowledge. So today's topic is going to be arthritis and exercise, as that was requested. Now, arthritis and exercise is a very vast area, and probably a lot of us already know somebody with arthritis, whether it's a family member, a friend, or actually a client of yours. But as you're aware, arthritis affects everybody differently. So we need to really start off by remembering that as the first thing before we even get into what it is and how to work with people with exercise that have the condition. Okay, so we're going to cover osteoarthritis and rheumatoid arthritis as they're the most common types of arthritis that we're likely to see. There are over 100 types of arthritis, including things like spondylitis and spondylosis. I think it's best practice if you do get referred any clients with these conditions to, revise that particular condition so you can be safe and effective when working with them. But for the sake of today's seminar, or chat should I say, we're actually just going to talk about osteoarthritis and rheumatoid arthritis. So if you have any questions as I'm going along, then do ask them. Or if you're watching this on a replay, then again, just use the comment section below to write anything that's relevant, maybe any experiences that you have with people with this condition, or again, ask any questions that are relevant. All right, so let's just get started because we're only going to keep these to 10 to 15 minutes long. The first condition let's do is osteoarthritis, as this is the most common form of arthritis. It's a wear and tear condition. That's what most people refer to it as. The people that have it themselves, they'll say I have wear and tear of the joints, and instructors tend to refer to it that way. Wear and tear is a very generic term. It can mean a lot of different things, and not just older people get osteoarthritis, it can actually affect younger people as well. You can get people in their 20s or 30s that develop the condition. The condition can develop throughout the body, so it typically affects the spine, the hands, the knees, the hips and the shoulders. And the younger people that get it typically have done something like sort of contact sports like rugby or football injuries. Football injuries always go for the knees. Everyone that gets injured in football, it's always going to be their knees, isn't it? So that's where they typically get their arthritis, and rugby players too. It's just an aggressive form. When it comes to getting older, it's likely to be a postural or biomechanical cause that causes this particular wear and tear, as we refer to it as. So we've got the joints. I don't want to go into too much anatomy, but just as a refresher, we've got the joints that are lined with cartilage, and cartilage allows for the joints to move flexible, smoothly, making sure that there's not any grinding or any pain in a healthy joint. When you develop arthritis, you start to lose the articular cartilage that lines those joints, either in one area or across the joint, depending on the severity of the condition. So when someone first gets arthritis, it might just be one section of the joint that starts to wear down. It's not the entire area, which means certain movements are going to be more uncomfortable than others. As the disease progresses and the osteoarthritis gets worse, then pretty much all movements requiring that particular part of the body are going to cause discomfort. So we just need to be aware of the disease severity for the client that you're working with, and it ranges from mild to severe. So osteoarthritis is a type of condition that, because of those changes in brief, is going to potentially cause inflammation. If you think about two joints rubbing together and they're trying, say for example the knee joint, and we're trying to flex and extend the knee, if there's no gap in between and the joints start rubbing on each other, that's going to cause pain and discomfort, isn't it? So that in turn is going to cause inflammation in that particular area as a result, because inflammation is a protective mechanism. It's trying to protect that part of your body from further damage. So someone with osteoarthritis in the knees, for example, may experience swelling. But what you need to understand in terms of the pathophysiology of the condition is inflammation doesn't cause the condition, it's a side effect of the condition. So that constant wear and tear, grinding and pain and changes in the actual joint itself cause inflammation to occur. Okay, so we go through the etiology and pathophysiology of these conditions a lot more in our seminar if you're interested in them. But for the sake of today, I think I'll just leave it there in terms of osteoarthritis being a wear and tear condition. So if we move then on to rheumatoid arthritis, rheumatoid is a completely different type of arthritis in that it's actually your immune system attacking your body's tissues. So your immune system normally looks after you, and any foreign bodies it gets rid of. But in the case of rheumatoid arthritis, there's a miscommunication, and what actually happens is your immune system sends out signals to go and attack your joints and the tissues surrounding them. So it's what we call a systemic condition. It affects the whole body, not just one particular area. So osteoarthritis, you might get someone say, I have osteoarthritis in my left knee and my right shoulder, for example. And that will always be the case, day in, day out. That's where they're going to have their osteoarthritis. It's not going to move. But with rheumatoid arthritis, because it's a systemic condition, it can affect the whole body. So someone might have a flare-up, which is what we refer to with this particular condition. So a sudden onset of pain, discomfort, inflammation in their ankle, for example. And then that particular area might then start to go into remission, which means the condition and the signs and symptoms decrease. But next time when they have a flare-up, it might start to affect their upper body, for example. So there is no exact consistency as to how it will affect the individual because it's an autoimmune condition. Now, it doesn't just mean that because it's going to affect anywhere you can't train them. You need to train their whole body, as I'll come on to in a second. But typically with clients, they will have areas that the condition will come back to. So it might be a case of their ankle and their shoulder, for example, are the main areas that are affected, but doesn't mean that they will be the only areas affected going forwards. So I think the important thing to take away from this section is that rheumatoid arthritis is an autoimmune condition. It can't be controlled very easily except for on certain medications. And people experience flare-ups, so sudden onset of pain. And when someone's having a flare-up, their joint will be hot, red, swollen, really painful. They won't be able to do things. And then it will go back into remission and it will go away. I'd just like to point out here that if someone is experiencing a flare-up when they've got rheumatoid arthritis, we do not exercise with them. It's an absolute contraindication as fitness professionals, so we need to get people to just kind of understand that you're not trying to be mean or rude or anything. It's for their own safety to just give themselves a week or 2 weeks maybe off, depending on how long their flare-up lasts for, and come back again and exercise when they're better, because you'll only cause further damage to them. Alright, so osteoarthritis is our wear and tear, our decrease in cartilage. Rheumatoid arthritis is an autoimmune condition that starts to attack the tissues in the joint. We see similar changes in the joint with rheumatoid arthritis as we do osteo, in terms of a decrease in cartilage, a change in bone structure, bony spurs, all of the things that do cause pain, but it's actually the inflammation in rheumatoid arthritis that causes that disintegration of tissues and bone structure. So there are similarities and there are differences between these two conditions. Okay, so signs and symptoms of both of them therefore do overlink, and we have things like clients experiencing pain, discomfort, stiffness, limited range of movement, and then it starts to affect things like activities of daily living. With rheumatoid arthritis, we typically get it in smaller joints in the body as well. So people might have it in their hands and you start to see it in the knuckle area, or in the ankles, as I said in the example below, or feet. So moving, walking, gripping things, turning the key in a door, making a cup of tea, all of those kinds of things can become quite challenging when you have rheumatoid arthritis or osteoarthritis in the smaller joints of the body. So in a fitness environment, be careful of gripping dumbbells, for example, or cable machines, or anything that requires extra grip if the client is unable to do so. So signs and symptoms, as I said from the very beginning, are going to vary per person, vary depending on the disease severity from mild to severe, and you need to therefore make sure that whatever you do recommend your client to do is individualised to them. I've got people I work with that have mild arthritis and you can't really tell, you can't physically tell they have pain in their joints, and they just take it easy and they work within their range of movement. To people that are severely osteoarthritic, they use a frame to walk with, they can't move their joints in certain planes of motion, which means certain movements and certain activities of daily living are really painful, and therefore they can't do most of them. So they're the signs and symptoms. If we move on to our jobs in terms of physical activity and exercise, what are the benefits that we can actually achieve with physical activity and exercise? So as I say, for every condition, there are lots of benefits. And you want to individualize those benefits to the people. So for example, if someone wants to be able to reach up into the top of their cupboard or walk up the stairs to be able to close the curtains, that might require stamina in the joint, it might require strength to be able to get out of the chair, or it might require flexibility to be able to reach up higher, for example. So there's going to be individual benefits, but the key ones that we want to just revise and refresh our memory on are going to be things like improving range of movement. One of the biggest ones is going to be to decrease pain, because that's the thing that people struggle to live with. Living in pain is the number one factor that most people don't do any physical activity and exercise. We want to be able to improve flexibility, improve activities of daily living, and basically reverse everything that the signs and symptoms suggest that someone might be experiencing. So there are lots of benefits. We can actually work to improve flexibility, activities of daily living, all those things I just said, over a period of time, but we need to make sure that they understand how they're going to do it, why they should do it, and most of all, how physical activity and exercise on a regular basis will get them there. So the biggest misconception that you need to start working with your clients to make them understand is that regular repetitive movement isn't going to cause more damage to their joints. Lots of people say, I have wear and tear of the joint, so why do I want to do something that's going to cause my pain to get worse, to wear my joints out more? I hear it all the time. I'm sure you've heard it several times before, even just family members as well as maybe clients. So that's when you need to say to them, I appreciate that the movements that we're going to encourage you to do could cause discomfort and some pain, but we only want to work within your pain threshold and within a certain range of movement, because long term we can strengthen those muscles that support the joint, and that's going to be what helps you reduce pain. There is a lot of literature out there. That's not what you're going to say to them, I'm telling you. There's a lot of research and literature out there that supports physical activity and exercise for reducing pain, improving functional mobility, and improving quality of life. And not that you want to show them that research, but you want to put that kind of information into words that resonate with them and really relate to what they're experiencing. So they need to see the long-term goal, not just the short-term goal. You need to say, if you stick at this, then actually the pain could decrease, you'll feel stronger, you'll be able to push yourself out of your chair a lot easier, you'll be able to walk further, you'll be able to get in and out of the car, up and down the stairs, all of the things that we all take for granted until we have pain and discomfort in that particular area of our body. So number one thing, and it's going to take time, just saying it to people once is not going to make them go, oh, okay, well, that's fine, I'll definitely do that then. You know, you have to really repeat that message and find different ways to kind of deliver that message. And hopefully testimonials of other people or other people in a class that can justify what the improvements are that they've seen will help people improve, help people change their behaviour and their lifestyle habits. And I've got a few people that initially thought no to squats. And squats are a really functional, effective exercise, but also can cause quite a bit of pain. So we need to make sure we do it in a safe and suitable way for them. But after 12 weeks, 18 weeks, for example, they noticeably looked at the difference and improvement that they had in terms of how many they could do in a certain period of time and how much less pain they were experiencing whilst doing it, because they've strengthened those supporting muscles. So that's something for you to maybe consider doing, or maybe implementing some challenges for your groups, such as how many sit-to-stands can you do in 30 seconds in a controlled and safe way, so that you can help them see improvements going forwards later down the line. All right, so far I've just mentioned about the etiology and pathophysiology of osteoarthritis and rheumatoid arthritis. I've just touched upon bear with me. I think I just lost connection there. I think we're still live. Okay, great. So we've done the pathophysiology and etiology, we've done signs and symptoms, we've looked at the benefits of physical activity. One thing I like to note at this point is when you're working with clients that have pain as a condition, they're going to be taking things like painkillers, aren't they? Such as paracetamol. And that's fine, and they might be taking something stronger than paracetamol as well. But what we need to remember is that that's masking pain. Therefore, they might come into your fitness environment and be feeling, pretty good for them. They're raring to go. They're going to push themselves a little harder because they feel great on that day. But when that drug wears off, that's when they feel it. So I often just remind people, remember, you're taking medication to numb your pain at the moment. So although we want to work and we want to develop your fitness, you still got to take it steady, and we still need to do this safely in order for you actually to see the benefits and not suffer from it. Because the only thing we'll get back from that is moaning, and we don't want that. So if we explain that to people, and I've said it to people before, and they're like, yeah, that makes sense. I haven't really thought about that. So I'll just take it a little easier even though I'm feeling good today. So remember, painkillers numb the pain sensation, so therefore we need to be aware of who's taking painkillers, how many painkillers they're taking, and remind them of those side effects. All right, so now we're going to move on to the actual structure of exercise. Now, in the seminar, we talk about this in a lot more detail, but we've got our ACSM guidelines, which is our American College of Sports Medicine guidelines for osteoarthritis and rheumatoid arthritis combined. The key differences between them is that osteoarthritis, as I said earlier, is more of a steady condition. So the pain and the discomfort and the limitations are going to be in the same joints each time you train with them. But you still need to ask somebody on a scale of 1 to 10, how's your pain today, or how are you feeling today in terms of range of movement, for example. Whereas rheumatoid arthritis is denoted by flare-ups and remissions. So again, it could severely change on a day-to-day or week-to-week basis for them. So it's always important to make sure that you verbally screen them, but just slightly differently from osteoarthritis. Well, in terms of our structure, we have our aerobic exercise, our musculoskeletal endurance and flexibility. All of these areas really important. None of them should be missed out. But all of the research and the literature suggests that if you get a combination of aerobic and resistance training, that's going to create the best results for your client going forwards. So that 50-50 split between aerobic exercise and resistance training. Flexibility is of course important for everybody, and we predominantly want flexibility to improve, if not maintain, the range of movement in the joints, so that those activities of daily living that I mentioned earlier are able to go forwards long term. So you're able to continue doing them long term. In terms of repetitions and things, everyone's going to be different. The ACSM guidelines actually say that maybe you only want to do 1 or 2 sets of 2 to 3 repetitions to begin with clients. My personal experience and my personal recommendation of that is to find out what your client can do already in an initial assessment and then go forwards with it from there. Most people can do 10, 12 repetitions of your traditional exercises, for example, bicep curls or hip abduction, but what they can't necessarily do 10 to 12 of is, say, sit to stands. So it depends on which exercises you choose to do as to how many repetitions. So just individualize it, use your knowledge, use your experience, and prescribe the right program for them on that day. So we've got those 3 columns, and you can research the ACSM guidelines, so I'm not going to go through the whole table. But a lot of ACSM and Research Arthritis UK and all of those kinds of charities that develop support documents to help people stay active at home really focus on functional exercises. So here are some functional exercises for you to start integrating into your sessions if you don't already, or just to remind you of how fantastic they are and to keep using them. So, for example, osteoarthritis in the knee, we want to encourage lots of sit to stands and quad strengthening exercises. So single leg extensions, either with ankle weights, with a resistance band, or if you're in a gym using a machine. Anything that targets the quads is going to be really effective. So those 2 in particular. Osteoarthritis of the hips, we're looking at hip abduction, so moving the hip away from the midline of the body, and hip extension, so moving it backwards. Really challenging exercises which can get quite painful if you do too many of them. So again, pick lower reps and build it up over a period of time. But they're really fantastic exercises for strengthening the muscles that support those particular joints. And as we said, if you strengthen those muscles, we can potentially decrease pain. So that's for that. Rheumatoid arthritis, we just want to focus on whole body exercises because it's a systemic condition. It can affect anywhere. So we want to keep the whole system nice and strong and active. However, we need to be very careful with resistance training, and we need to be careful with not overdoing it because you open up your immune system and can potentially induce more pain and discomfort. So we work on just a completely normal program like you would for anybody, but just take the intensity down. So working our upper body, lower body, flexibility, everything that you normally would, just take it nice and steady. All right, so we've covered a fair bit in there for that refresher so far. If anyone's got any questions about those, then please put them underneath. I'll put the link above to the arthritis seminar in case anyone's interested in having a look at that and listening to that as we go through all of this stuff, but in more detail, and also have supporting resources that will help you with it. So hopefully this has just refreshed your memory, because I think a lot of you will know this anyways, in terms of the different types of arthritis, the two ones we've just covered, osteoarthritis and rheumatoid arthritis. Maybe research spondylosis and spondylitis if you have clients with those. We looked at the main signs and symptoms. We then touched upon the benefits that physical activity can help with, so ideally reversing all of those signs and symptoms, so improving mobility, improving activities of daily living, etc. And then we've just touched upon some key physical activities and exercises you can encourage people to do. And don't just leave it as they just do them in your session. The more often they do, the better they'll get, the stronger they'll get, and the more successful they'll be at achieving their goals. So hopefully that makes sense. Like I said, leave any questions below. I think that I'll leave it there for today. We'll do another revision refresher topic next week. So if you have any topics that you would like us to cover, then again, pop it below. If not, I will speak to you then. So I'll see you all guys later. Bye.